Thank you for that kind introduction, and thank you all. I appreciate the chance to come here and talk with you today. I'm especially happy to be here because Pennsylvania has actually a very innovative way of managing behavioral health services for people on Medicaid, which is not everybody you all are involved with, but many of the individuals that you all work with. The children their health care is funded by Medicaid. And unlike most places where the behavioral health services for people with Medicaid are managed by traditional managed care companies, in Pennsylvania the ultimate responsibility is actually with the Human Services Department of each county. So each county really decides how they want to manage behavioral health services for children whose health care is paid for by Medicaid. So I'll tell you briefly just who I work for, but I think the fact that we're here and able to have this conversation is important because you all are all connected with county and state organizations, and so you really have the ability to influence care and policies for the health of the children that you work with. So within Pennsylvania, people can choose a physical health plan if they're in Medicaid, but their behavioral health plan is chosen really by the county that they live in. So everybody in Allegheny County has the same health plan managing their behavioral health services. Everybody in Westmoreland County has the same. Everybody in Philadelphia County or Erie County or Lackawanna or Lucerne have the same. So I work for Community Care, which is part of the insurance division of UPMC. So in addition to all the provider and healthcare services that Judge Baer was talking about, UPMC also has a series of insurance companies. It's actually grown a lot over the last several years. It's now the second largest group of provider-owned insurance companies in the country. The largest is Kaiser, but this is now the second largest. And one of the companies is a company called Community Care, and it's a not-for-profit 501c3 that was really built when Pennsylvania began to implement its Health Choices program for behavioral health services for people on Medicaid. So the company corporate headquarters are in Pittsburgh, but we do this work for Allegheny and for 38 other counties around the state. So we have lots of people that we collaborate and who we work for, a few of whom are in the room here today. But it's really been a great opportunity for us to really work in partnership with counties and with folks like you all, as well as advocacy groups, providers, and people receiving services. So I wanted to, in talking today, talk a little bit about a project that your roundtable actually initiated, and talk a little bit about how that got started, what kind of information the work group reviewed, some of the concerns and opportunities that we saw with that, and some of the recommendations that were made by the work group, and then some potential next steps. And again, that was the roundtable brought together a multidisciplinary team, and you can see on the slide all the different organizations that participated. Community Care was invited to participate, and I want to give credit to a child psychiatrist who works with us, Gail Edelson, who did a lot of the work on our behalf with this, but who is out of the country, unfortunately, today, so she couldn't join me here. So the work group's mission was to recommend a system of oversight focusing on children and youth involved in the dependency system to ensure that those with mental and behavioral needs have a plan for appropriate and effective interventions. So the group was not just focused on psychotropic medicines, but it did create a work group a few years back now that was really focused on the use of psychotropic medicines for children in the child welfare system and the effects on the health of those children. So you can see Catherine Greco and David Schwilly led the group, and there were several subgroups put together. And people from several different counties participated. So it was really a statewide group that focused on lots of concerns that had come up around the state. And really the concerns that the group focused on have really been national concerns, but we were able to dive a bit into specifically how they presented in Pennsylvania and what our concerns and opportunities were. So we reviewed lots of background information, including national reports. There were several groups that put out best practice guidelines around the use of psychotropic medications in children and adolescents, and we reviewed those. We looked at input from programs that other states had put together. We had some experts in the area come and participate in the proceedings and provide information. Parents and children were interviewed and also participated in the group. So I'm going to talk today a little bit about national trends, what's occurred, what's happened in Pennsylvania, and then there have also been some reports from a few different places that talk about use of medications in children in out-of-home placement. So the first place to start, and I realize this is a little hard to read, I'm sure, from a distance, and I don't know if the slides are posted for you all, but if not, if you want a copy, I'm happy to send them to you. Just give me your card afterwards. So there was a overview report done, and this was back in 2005, but the evidence hasn't dramatically changed. There have been a few updates and additions, which I'll comment on. But this was looking for use of second-generation antipsychotics, which are the antipsychotics are the group of medications I'll primarily focus on, because that's the group of which there's the most concern in children. So it was the use of second-generation antipsychotics, which was a group of antipsychotics developed over the last 20 years that were at least promoted as having fewer side effects than the older medications. So it was evidence for the use of antipsychotics among almost 12,000 Medicaid recipients across many different states and studies. And what they found was that, so you can see here, on the bottom they listed when the evidence was strong, plausible, weak, or none. And they tied the use of the antipsychotic medication to the diagnosis for which the child was being treated. And we'll talk a little more about that. The diagnosis doesn't give, obviously, a full picture, but this was a start. So you can see, if you look at how many of the children had a use for which there was strong evidence, and this was like if there was an FDA indication. For many of the medications, it was really very weak. There was one medication, risperidone, that had an FDA indication for bipolar disorder and other psychotic disorders in children. So there was some indication for that. But you can see that in total, for a little under half the children, there was significant evidence that the medication was indicated for the disorder that the child had. And for, you can see down here that for about the same number of children, there was very little evidence that the antipsychotic medication was indicated for that child. So, and this was from 2005, and we'll look at another slide later, but there was actually continuing increase in the use of antipsychotic medications till the last few years. So this actually probably so this actually probably was understated compared to the use at least a few years back. So again, among users of risperidone, 64 use had strong evidence base. Among use of aripiprazole, there was very little evidence. And again, this has changed a bit, and so the exact numbers really aren't important. What is important is that, like is the case with many classes of medications used in children, there aren't all that many studies in their use in children. So it doesn't mean that it's wrong to use them, but it means, I think it raises some cautionary flags, suggesting that we have to think thoughtfully about the use and about what the risk-benefit ratio might be. Of the youth who did not have evidence-based use, and again, our analyses in Pennsylvania, you'll see, are similar to this. Over half the youth, about 58%, had a diagnosis of attention deficit disorder. And other frequently observed diagnoses among the children for whom there wasn't a strong indication for the use of antipsychotics included children with oppositional defiant disorder, depressive disorder, a different attention deficit disorder without hyperactivity, and other conduct disorder. So you'll see most of the children who received antipsychotic medications when there wasn't a clear indication were children who were probably at least annoying other people, or having real significant trouble getting along either with their peers or their teachers or others. This slide shows kind of general increase in use of psychotropic medications among children. You can see, so this, the dark blue bar represents office visits by young children during a period of 1995 to 98. This bar is 99 to 2002. This bar is 2003 to 2006. And this bar is 2007 to 2010. So you can see the number of visits, and this is number of visits per 100 children, related to attention deficit disorder medications went up significantly over time. Anxiety medications went up slightly. Antidepressants were essentially flat. Antipsychotics went up significantly, certainly during the early period, as did the use of mood stabilizers. So this is just to set the frame. You can see that the use of psychotropic medications generally in children went up over time, which again, in and of itself, is not necessarily good or bad, just means that we want to look closely at it. There was another article that came out really just last year this article looking at trend in office-based medical visits. It looked at the SGA as second-generation antipsychotic use with other medications. And you can see that over the midpoint of that period, 2004 to 2008, second-generation antipsychotic use increased overall by about 22%, and 85% of the children were getting additional medications. And this is also consistent with our Pennsylvania data that we'll go over in a moment, which is most of the children receiving antipsychotic medications are receiving other medications as well, and usually got the other medications first, and then they weren't necessarily all that effective, so people added an antipsychotic medication. Nationally, the highest rates of antipsychotic use were seen in children in foster care, disability Medicaid programs, or people who had been hospitalized in behavioral health settings. The most significant growth over time in the use of antipsychotic medications were children who were on Medicaid, not due to disability, but because of poverty. Use in children who didn't have attention deficit disorder, and use in children who didn't have a comorbid intellectual disability. We tried to look somewhat further into these points and themes, and we found that there was another study that had come out a few years ago that indicated that the use of antipsychotics among children on Medicaid had gone up significantly over time. So this was the percent of children in a cohort in a particular year who had a prescription for an antipsychotic medication. So this is a national study, and you can see it went up from about 2% to 4% in the early part of the 2000s. The number among privately insured youth also went up significantly, but started from a much lower point. and it looked like the use of antipsychotic medications for things other than bipolar disorder or other psychotic disorders was much higher among children in the Medicaid population, and that the rise was significantly greater among children in Medicaid. So, in light of this work, over the last, now I guess, 7 years, Community Care has been looking at the use of antipsychotics in children in the different counties that we work in. So we work for 39 counties around the state. The 39 counties are divided into about 10 contracts. So these rates are for different contracts. And you can see that there's significant variation in terms of how frequently antipsychotics are used around the state. You can see in one county it's under 2% of the children, so which is around half or less than half of the use in some of the other counties. And the other counties are around that, looks like around the national average of around 4% of children in Medicaid receiving an antipsychotic. This is in a particular quarter. If you make it a particular year, in some areas it's up to around 5%. One thing you will notice is in the last few years, it looks like the use of antipsychotics is at least flattened and maybe starting to, looks like was starting to trend down as of about 3 years ago. Again, this is another way of, this is an annual rate. Before, what I showed you was quarterly rates. This is an annual rate of use in antipsychotics. So you can see it was up over 5% in some areas, although it looks now like it's trending down, and I'll talk more about that in a minute. So there are several reasons that we were concerned about the use of antipsychotics, and especially what looked, when this group started back in 2011, like an extended period of growing use of antipsychotics among children that were cared for in the child welfare system. And one of the, there are lots of reasons that we're concerned, you know, certainly one being that you don't want to ever give someone, especially children, a medication that's not going to be helpful to them. But particularly because there are cardiometabolic risk of antipsychotic use in particular. And people used to think it wasn't all that big of a deal in children, because children don't usually have lots of cardiometabolic problems. But it actually turns out there are substantive risks for children as well. So this was a study published now a couple years ago, looking at the use of antipsychotics in children and the side effects of antipsychotics in children. And you can see the average age was about 14 years old. Almost 60% of the people involved were male. And you can see the race distribution as well. You can see about 30% of the children had what's considered a schizophrenia or a related illness. Most of the other children had a mood spectrum disorder. Many had bipolar disorder. And then some of the children had disruptive disorders, things like oppositional defiant disorder, attention deficit disorder, and so on, for which there's really has not been clear indications. There was an indication added several years ago for risperidol and now I believe for aripiprazole for agitation in children with the diagnosis of autism spectrum disorders. And they looked to see what the impact was of several different antipsychotic medications were on different cardiometabolic indicators versus children who did not have treatment with these medications. And what you can see was actually really concerning, which is over a period of 12 weeks, on average, children gained 10 or more pounds if they were on an antipsychotic medication. So you can see the mean weight to start was 120 pounds, and children on average gained about 10% of their body weight in 12 weeks. So it was really very dramatic weight gain. And people knew that weight gain was or is an issue with these medications. Before the study came out, though, no one realized it was a substantive concern in children, because although there's clearly lots of obesity now among children, you don't think about rapid weight gain in children as something that's likely to happen, but it clearly does with these medications. They also looked at a number of blood tests for things like sugar, glucose, insulin levels, cholesterol levels, and found that a number of the medications influence at least some of these factors in a negative way. At Community Care, we've worked with a number of counties and physical health plans to try to do an analysis to see whether or not children are receiving adequate monitoring for these issues when they're on antipsychotic medications. Now, about 10 years ago, the American Psychiatric Association and the National Endocrinology Association came out with some recommendations for monitoring of adults receiving antipsychotic medications. And nobody has specifically, there's not been a national organization that's come out with specific guidelines for children. There aren't any. But in the absence of any, we and many others have encouraged pediatricians and child psychiatrists to follow the same guidelines. And certainly after this study came out that we just looked at from a couple years ago that showed that a number of the medications can alter lipids and glucose, that people have similar monitoring. So our results among adults, which are down at the bottom, were actually at least modestly reassuring. The lab that you want to especially monitor is the serum glucose. Certainly you want to look for cholesterol as well, but that's kind of probably usually less critical in children. But the medications appear to predispose people to diabetes, so you really want to watch people's blood sugar closely. And you can see in adults down here at the bottom that if you look at the last two groups, which is people who had glucose and their blood cholesterol checked, or people who had just their glucose checked, among adults it was about 72%. And this was based on the labs we had available, which are, for reasons I won't go into, are probably like 80 to 90% of the total laboratory evaluations people have done. So the real rate's probably a little higher than that for adults. So that's, it's probably close to 80% really. But you can see in children that rate's only about 50%. So it looked like not only were more children getting the drugs, but and this number is considerably higher than it was about 4 years before. We've done this every couple years. And when we first started doing it in 2008, the number was about 25%. So it's gone from 25 to 50, which is good, but there's certainly further to go. Yeah, so you can see, I won't go into the details, but we tracked this over 2008, 2010, and 2012. And there's certainly been an improvement in all these categories over time, but there's certainly still significant improvement possible. We did some additional drill down looking at children who were receiving antipsychotic medications to see who was prescribing them. So one concern is if a child's getting an antipsychotic medication, are they getting it from a psychiatrist or is it being prescribed by a pediatrician? And it does look like almost all the children are receiving the prescriptions from psychiatrists. The databases that we're able to use to try to identify what practitioner specialties are not perfect, but certainly the vast majority of children receiving them from psychiatrists. In rural areas are probably more likely to be general psychiatrists than specially trained child psychiatrists. And most of the children are receiving concurrent behavioral health services. So people aren't giving antipsychotics to children when they're not getting any other behavioral health treatment. And most of them are receiving in what we would think of as relatively intensive community-based services. So most of them are receiving what we often colloquially refer to as wraparound services or behavioral health rehabilitation for children, BHRS services, or family-based mental health, which is a more intensive, not more hours, but more therapeutically and often intensive therapy in the community. So it did look like children who were receiving antipsychotics were not getting prescriptions from pediatricians who hadn't thought through the problem or hadn't been otherwise evaluated or assessed. So those findings we thought were good. The areas that were of concern that we found in our Pennsylvania analysis really reflected many of the findings from the national studies, which was that many of the children who are receiving antipsychotic medications don't have an indication either approved by the FDA or otherwise supported in published literature. So it appeared that many of the children who are receiving antipsychotic medications were had been evaluated by a psychiatrist and were receiving psychosocial interventions. On the other hand, it looked like they were receiving the medications for indications that weren't clear, and so it clearly raised the it clearly raised as an important concern that children really be closely monitored in terms of the impact of the medication, and that there's really an ongoing, thoughtful risk-benefit evaluation done of the child's use of the medication over time. So, it looked like children were receiving antipsychotic medications often as a third, fourth, fifth line treatment intervention. So people weren't going to it, as a first line intervention, particularly if they didn't have an indication for the medication. On the other hand, it looked like the medications were being used for in circumstances where there wasn't really any clear literature support that they might be helpful. So, often in medicine, people don't respond to usual treatments, unfortunately, or typical treatments. So then, many people do, but 10, 20, 30% of people don't respond to the usual treatments for whatever the problem might be. So then you have to make a decision about whether it's worth trying something for which there's not a clear indication. And I think often the prescribing doctors, as well as the parents and other people working with the child, probably feel torn to some degree. They want to try everything possible for the child. On the other hand, you don't want to make somebody worse or give them side effects from something that's not going to be useful. So I think each situation is probably different, but what it does mean is that people need to think thoughtfully about the next steps. So the areas of concern included the fact that many children don't have an indication that's supported by literature. There are significant medical risks associated with antipsychotics, and at least half of the children really didn't have appropriate laboratory monitoring for potential abnormalities in their blood sugar or cholesterol related to this. So there have been lots of interventions in the medical settings and education to try to address the rising use of antipsychotic medications, including, there have been lots of articles in in popular press and newspapers about use of antipsychotics in children, as well as in medical journals, and lots of presentations at medical meetings and so on about the concerns that were raised by this group. So at Community Care, we work with the counties we work for to try to add to that. So we sent letters to physicians on the current recommended guidelines for monitoring. Their articles, we published articles about it. We met with some of the large provider groups in different counties. We go out and review records periodically, and we included monitoring of antipsychotic medications and when we did record reviews. We also sent information out to put articles out for members and parents. And we tried to support particularly children and youth efforts to get information out to members' guardians about antipsychotic medications and try to give them some tools that they could use. In addition, the physical health plans also work to address this by requiring prior authorization for antipsychotics in children. There are, I think, now 9 physical health plans for Medicaid recipients in different parts of the state, and each plan has different guidelines. Some of the plans require prior authorization for every antipsychotic medication in every child. Usually if the child has bipolar disorder or another psychotic disorder or autism with behavioral challenges, the prior auth goes through almost with just some brief information from the prescriber, but they do require some more intensive evaluation if the child doesn't have those disorders and somebody's looking to use antipsychotic medications. And really look for evidence that there's been appropriate evaluation and alternative interventions tried, and that there's appropriate lab monitoring occurring. So the roundtable committee looked at all the information that we've reviewed here today, and also looked at a number of guidelines put out by various professional organizations around the country. And particularly the American Academy of Child and Adolescent Psychiatry put out a very nice review last year looking at the context for prescribing psychotropic medications, phases in treatment, considerations for child-serving agencies. And so this is really a nice reference for child welfare and other agencies related to foster care. There was also a guide put out now probably about 4 or 5 years ago called The Treatment of Maladaptive Aggression in Youth that has a series of guidelines about use of antipsychotic medications in children. So these was kind of general background information around use of antipsychotics in children generally, particularly children in Medicaid. Then, as I'm sure most or all of you have heard, there was also, about 2 years ago, there was a large national study published, actually came out of a group at the Children's Hospital of Philadelphia led the research, looking at the use of psychotropic medications among children in foster care, not just at antipsychotics, but at all psychotropic medications. And so we worked to replicate that, looking at psychotropic prescribing. It says foster care. It's really children in out-of-home placement, which is the indication that we get in the data feeds that we get from the state. There's significant overlap with foster care, but not one-to-one. We compared it to children who were not in out-of-home placement. And so this was the study done by the General Accounting Office that included certainly folks from Pennsylvania participated in doing the analysis. And in the national study, what was found was that there was a ratio of somewhere between 2.7 and 4 in terms of the rate of psychotropic medication use and this was children in foster care in 5 different states. So you can see that the rate of psychotropic medication use, this is any psychotropic meds, so included stimulants and antidepressants as well as antipsychotics, in the Medicaid population generally was in the 5 to 10% range, and in children in foster care was in the 20 to 40% range. So this was the summary of the report essentially said, we're concerned because the rate of psychotropic use among children in foster care is so much higher than the rate of psychotropic medication use among the general population. The folks who wrote the report were careful to say, we don't know for sure if this is bad or good. I mean, you'd expect the rate of behavioral health challenges to be higher in children, probably on average in foster care, than children who don't need placement outside the home. So it's not surprising that it would be somewhat higher, but the rate of being up to 4 times higher was striking and concerning. And these were the demographics of the folks that they looked at. These were the rates and these were the medications filled. And so you can see that stimulants among children in foster care, stimulants were common, as were antidepressants and antipsychotics, as well as mood stabilizers. And you can see it was the frequency of antidepressants is somewhat higher among children in foster care. The frequency of antipsychotic use was much higher. These were the diagnoses of children in foster care received the medication. You can see the incidence of depression was high and the incidence of oppositional and defiant disorder was high. And for the non-foster care children, the depression was also high, as were adjustment disorder, which is a diagnosis. Adjustment disorder has been defined as a brief kind of overreaction to a stimulus. It's usually time limited and not something that you'd expect to see a lot of pharmacy use around. So so there was clearly significant use of medications in foster children that's higher than the general population. We also did an analysis, and this is data from community care, data looking at polypharmacy in children who are in foster care. Because certainly an additional concern among children in foster care is not just that the rate of medication use is relatively high, but that they tend to have several medications at one time. And so we looked at this in children as 3 or more medications for at least 90 days. And we defined at least a 90-day period because sometimes people are switching from one medication to another. And so that if we did it for a shorter period of time, we thought it might be a bit misleading. But usually switching is done within a shorter period of time than 90 days. So you can see the number of children who were on 3 or more medications, children in foster care, for at least 90 days was around 10%. And the rate for children who are not in foster care is about half of that, is roughly half. You can see the number of children who are on more medications than that is relatively small. But there's still, a significant number of children in foster care are getting multiple medications. Oh, and here is the data for the children out of foster care. So you can see it's a little less than half. So the conclusions from the national report from the GAO was that foster children are prescribed psychotropic drugs at higher rates than non-foster children. This could be due, at least in part, to the foster children's greater mental health needs, higher history of trauma, and challenges related to coordinating their medical care. So maybe to some degree they tend to get more medications or a higher rate of polypharmacy because they might be moving from one location to another. They might be changing doctors who maybe aren't necessarily aware of exactly what happened with their prior setting. And the GAO recommended that Health and Human Services consider putting together guidelines for states to use, addressing this. So the Roundtable Committee used this certainly as part of the information, used the community care analyses as part of their findings. They also looked at some best practices that were developed by the American Academy of Child and Adolescent Psychiatry, and these are also things that we thought were really important to include in practices endorsed by the Roundtable. One was that there clearly be consent to the medication trial by either the natural parents, if they retain the ability to give consent, or by whoever the substitute caregiver is. That there be some oversight process, including monitoring rates of prescriptions. A handful of states have now implemented guidelines which allow or in some cases require consultations by child psychiatrists when antipsychotics are prescribed, and to create a website about drugs for clinicians and caregivers. Certainly one of the themes that the committee also considered was that there have been a number of studies that suggest that a number of behavioral health issues, especially in children, but not only in children, are related to prior history of trauma, and that children may be getting medications instead of appropriate trauma-informed treatment, and that trauma competency should certainly be encouraged as part of the treatment modalities for these children. So these were the recommendations that the committee developed. The first was to collaboratively develop guidelines or policy regarding oversight and monitoring of psychotropic medication for dependent children in Pennsylvania. The policy development certainly was to include informed consent, making sure that children had adequate screening, assessment, and that there be a statewide red flag monitoring system. And I'm sure many of you all use the red flag concept now in your work, but it's essentially if anybody identifies a quality issue, they're allowed to raise their hand and say, we have to talk about this right away, I have a concern. So there was a recommendation that really be built into the treatment processes. The second was that their state explore the possibility of providing incentives to providers who attain positive outcomes for children in the dependency system related to mental and behavioral health treatment, including psychotropic medication. And there was a sense that this couldn't really be done until there were some clear guidelines around psychotropic medications to tie the incentives to. And I think it's certainly a good recommendation. I think the question is what behaviors do we want to incent, and can we gather information on to effectively incent? So, for example, we could look merely at the rate of antipsychotic use in children under the age of 18 and give providers a financial incentive if their rate of use is low. The question is, or I think a question is that in and of itself an adequate measure? So, someone could say, well, I'm going to get a financial incentive if I don't prescribe antipsychotic medications very often, so I'm going to really not do it at all. Maybe that person doesn't prescribe them, maybe even sometimes when they're indicated. So, because their incentives tied to, having a lower rate of psychotropic prescribing. So there's certainly ways to address that, but it's, I think there are some complexities involved in figuring out how to do this in a way that's most effectively supports good care for children. The third recommendation was to facilitate training on oversight of psychotropic medication to support what's expected of all partners in the child welfare system. So there has been support to develop psychotropic medication questions to give guidance to judges, legal representative, caseworkers, so on. And there are lots of relatively, maybe not lots, but several relatively brief guides on psychotropic medications available for people outside of the medical system to use when they're working with children. And I think what's important with this issue is, with this recommendation, is partly the content, but it's also partly we get everyone thinking about it and thinking about the pros and cons and when children should be on medications or not, it will really help us begin to influence the culture of the system. I think we want to support the development of a culture that's not, black or white around medications. Not children should often get them if they have a problem, or children should never get them, but really that there should be a thoughtful process involving the team of people and working with the child, especially their guardian and the child, to think about, when medications are indicated and to monitor their use over time. A fourth recommendation was to collaborate with the Children's Hospital of Philadelphia's Policy Lab, which was the lead driver of the GAO report, to provide counties with data specific to their usage of psychotropic medication with their child welfare population, and to help the counties develop county-specific data and protocols around psychotropic medication use for children in the child welfare system. And there currently are additional analyses underway, and it is a topic at a number of the local children's roundtables as well. And then the fifth recommendation was to develop a psychotropic medication resource section on the Office of Children and Families in Courts website, while really trying to explore even a richer website resource for particularly families as well as other people involved in serving these children. And the sense of the committee was also that there be ongoing work to really try to better understand what's driving the use of medication use in foster children in Pennsylvania. Clearly, foster children are medicated at a higher rate, as we've seen, than other children. Some of the red flags that have been used in other settings, or that the committee suggested that we look at in Pennsylvania as a red flag that would bring a child's care for more intensive review. One would be lack of documentation around informed consent. The second would be using the psychotropic medications for off-label use, which is primarily an issue around the antipsychotic medications. And a third one was antipsychotic medication use itself. Another was polypharmacy, use of psychotropic medication for young children under 5, and I didn't show that in the analyses. And most of the psychotropic medication use is in adolescents. There's some in children, but there is some, a modest amount, but there is some in young children as well. And then the last would be if the medications are being prescribed by a primary care physician for disorders other than ADHD or depression. And in terms of guiding our thinking about the use of psychotropic medications in children, Dr. David Rubin, who leads the Children's Hospital Policy Lab, suggested that we use the following questions. One is, actually, before we even think about medications, to take a step back and think about the child's diagnosis. So one is the child's diagnosis correct? So, maybe the reason the child's treatment hasn't worked is not because people haven't thought about effective treatments for the diagnosis, but maybe the diagnosis is wrong and there are alternative treatments that should be considered, medication or psychosocial. The second is, if the child's on medication, what is the medication's intended effect, and has it been effective? And I think particularly early on when medications are started, it's certainly reasonable to think about some very structured assessment of the child's, whatever the target symptoms or behaviors are, on at least a monthly basis. The third is, are we doing appropriate monitoring for adverse effects? The next is, if the child's doing well, have we thought about tapering the medication? And I realize this is often a challenging issue to review with parents or guardians, because if a child had problems for a long time and now they've had a period of 6 months or a year where they've done better, the parent or guardian is going to have a natural reaction of, this child's like doing way better than they've ever done, don't touch anything. On the other hand, the medications do have some side effects. So again, it's not a black or white decision, but one that I think it's appropriate to have an informed discussion about with the parent or guardian. And especially and as well as what's the opinion of the treating physician. So that's the end of my formal presentation. I know we have some time left for questions, and I'd be happy to take those.
I thought I saw a slide that
You're welcome.
showed the evaluation for ethnicity, and I don't think you discussed that.
Yes, I'm happy to look at that.
Dr. Schuster,
So
would you please repeat the question? We didn't hear the question.
Yes. So the question was, there was a slide on ethnicity, and this was this slide is from the study that looked at weight gain in children put on antipsychotic medications. So, to be honest, I don't. I'm guessing that it reflected the ethnicity of children in treatment in the locality where they did the study. But in general, certainly there's a higher rate of particularly antipsychotic use among boys and among minority youth than there is among Caucasian youth.
I think
or
the
girls.
question is, on page 15, the ethnicity question, the ethnicity slide on number 15 at the top. I think maybe that's where the question is.
Okay, this is slide 15.
Yeah, that was
So,
and actually, that was my follow-up question, too, where it's noted that over half of the children in the foster care demographics are African American, and they're receiving more of this type of medication.
yes.
So I guess the question is, I don't see where that's noted anywhere in the recommendations or questions as to why this is the case.
As to why the African American
As to
children
why-
are more likely to.
That's one question, but also, I don't see it anywhere in the recommendations where this specific issue may be addressed, or in any of the questions, the thinking questions as to why we're giving a lot of our kids psychotropic medications. And then sort of another follow-up, what happens in the long term? I know you talked about weight gain, but what
Right.
else happens in the long term to our kids who are being over-medicated or receiving so many of these medications?
Right. So in terms of why African American children receive medications more frequently relative certainly to their rate in the general population, and I don't know if, so this is, this is from Community Care's data. So this is based on enrollment data from the state, and the I think for one, I'm going to have to check because I think that number, I think probably white and other are switched and mislabeled. So to be honest, I don't know how the, so that's the general demographics of foster care. So that's not the demographics of the children on medication. That's just the demographics of the children that we had out-of-home placement data on in general. So that is, you know, we work mainly in Pennsylvania, and we work in a lot of rural counties, so I'm certain that's higher than the overall rate of African-American population on Medicaid in the counties that we work in. Why the placement in foster care is higher is, you know, a complicated question I could speculate on, but that's outside really my area of expertise. In terms of long-term side effects, you know, the short answer is, on the whole, we don't know. So we do certainly have some, we have information about weight gain. Certainly if people are on medications long-term, you know, people can measure metabolic parameters. My guess is the question you're also interested in is what's the impact on behavior, personality, and so on over time. And you know, the answer is that nobody knows. I think nobody really knows for sure. It's really difficult to do even a one-year study, you know, structured study. The the longest term studies that we have for use of medications, of psychotropic medications, even in adults, go out about 18 to 24 months. So the question is a really good one, and I think what it reinforces is that we need to be really thoughtful about when medications are used, and you have to really weigh the risk and benefits, including the proviso that you don't know what all the risks are long term. Now, I have to say, we also don't know what, the long-term, we don't know definitively, really, what the long-term impact is if a child has, in theory, let's say, problems with attention or impulsivity that really impair their ability to function within school, and what impact that has on them long-term. So I'm certainly not advocating that people use medications in any way cavalier. I just think there's lots that we don't know, really on both sides of the risk and benefit piece.
Sorry, we were having our sidebar here. We noticed that Philadelphia was left out of that whole demographic, which might have just skewed those numbers even further. But
Yeah, well, community
thank
care
you.
doesn't do the work for Philadelphia. Yeah, so I'm sure it definitely skewed the number of African Americans, including the population. So Philadelphia actually created their own company, Community Behavioral Health, that manages behavioral health services for people with Medicaid. That's part of the county there. So we don't have access to that information.
Okay, thank you.
Sure, thank you.
So two kind of colloquial observations that I think people have about this topic are that treatment is not connected to the prescribing clinician, that the two services are provided differently and often without any connection, and second, that the prescribing clinician for the medication is seeing the child in a very shallow, drive-by, quick kind of way. Not to be too pejorative about it. But given that you're representing the entire insurance industry for us today and recognize that we don't want to shoot the messenger, perhaps you could offer some thoughts about best practice on the connection between therapy and medication, these two different professionals, and how long a child should be and how frequently should that child be with the prescribing physician who's offering all this over-medication.
Yeah. Well, I think the point's a good one, certainly, that the medication should be well integrated into the child's other treatment. And I think it's variable, clearly. Sometimes the doctor is seeing the child in the context of a larger treatment program, and then it's probably relatively easy for it to be well integrated. Often the child's seeing a psychiatrist who's not employed by or otherwise formally connected to the other treatment program, and then it does require some energy, certainly on the program's part and on the doctor's part, to make sure that treatment's coordinated. I think, we could certainly think about, I think there's a range, and, there's probably, on the whole, psychiatrists aren't all that different from other physicians, and, some do a really good job of coordinating their care with the other physicians taking care of people, and not enough of them. So I think probably it's something that, to some degree, we probably need to think about as a system. Because certainly I think the place where it's most challenging is in some of the more rural or underserved areas where there's not very many physicians. There's a lot of pressure on the doctors to see lots of people quickly because there are no other doctors, and if they don't see them, nobody else will. On the other hand, that doesn't solve the issue about making sure that services are well integrated or connected for that individual child. So we have done, I think as a system, a reasonably good job often of creating interagency team meetings or processes to make sure, for example, if a child's going to a residential placement, that there is an interagency meeting that includes lots of people providing care for that child. If a child's having another significant clinical service or is not doing well, there's often a community-wide meeting of agencies to approach that child. And I think we could think as a group about, are there times when we want to add an indication for an interagency meeting for a child who, say, has been on a medication for 6 months, or an or on more than 3 medications for 6 months, or on an antipsychotic medication for a year, or what have you. There's not like a goal. There's not a exact moment to do that. But I think it's probably hard for many of the physicians to actually do more than they're doing, just because of the requests made of them to see lots of people relatively quickly. But clearly we want to make sure that it's integrated. So I think it's something that we might want to well think about as a system. In terms of how often the doctor should see the person, to some degree it depends on, I think, how well integrated in a system they are. If they're working as part of a team and the team's seeing the child frequently and reporting back to the doctor, they may not need to see him with great frequency. If, on the other hand, they're disconnected, then they'd probably want to see him, more frequently than not.
I think many of us are under the impression that these are medications that should be prescribed by a psychiatrist. I've heard you say a couple times here that earlier it was good that so many pediatricians were prescribing it. And just in answering this last question, you mentioned that in many rural jurisdictions there are not even pediatricians and you have general practitioners prescribing psychiatric meds. Could you speak a little to that idea that really this should be limited in its use to prescriptions by psychiatrists or not?
Yeah, and I'm sorry, I probably wasn't clear. I think in rural counties they're often being prescribed by general psychiatrists, so people who haven't received lots of specific child training. They're usually not being prescribed by general practitioners. So I think that was one of the recommendations, actually, that the state consider a system in which some child psychiatry consultation is required, even if the doctor doesn't see the, isn't able to see the patient because of distance issues or what have you, that there's a child psychiatrist involved in at least, reviewing the records or talking with the prescribing physician about the case. One of the physical health managed care plans, UPMC has actually required that if a child is under 12 and doesn't have an indication for one of the medications, if they don't have bipolar disorder or autism with agitation, that the documentation has to go to a child psychiatrist actually for review, and then they'll often do a consultation with the prescribing doc. It actually led to a significant decrease, about a 30% decrease in the use of antipsychotic medications over the first year.
Well, given that and all the problems nationally, would community care behavioral health consider making that a requirement before approving prescriptions for psychotropic meds for kids in foster care if there isn't a consult or a child psychiatrist prescribing the medication?
Yeah, we don't pay for the medications. The physical health plans do, so we can't require it. We are having psychiatrists look at the medications if children are in residential care or if they're in inpatient treatment. We don't always know exactly when children in routine outpatient care might be getting certain types of medications. We are sending letters to physicians who have children who are on 3 or more meds for 90 days or more to say, these children are on the meds, please review this again. There are particular side effects with that.
Hi.
Hi.
So we've been talking about trauma a lot, right? 2 years ago, we focused on being able to identify it, and now we're learning about the improvements that people can have in their lives if we address their issues specifically with trauma-informed care. My curiosity is, we know a lot of the symptoms of trauma are very similar to the symptoms of a lot of these diagnoses that our kids are ending up with.
Absolutely.
So is there going to be a push from the insurance side, from the physician side, to expect trauma-informed care to be tried and exhausted before we're moving into diagnoses and follow-up medications? Because the question you posed, a child's doing well on a year of medication, when do we taper? I'm wondering, did we ever address, identify if it was trauma in the first place and try to alleviate it as opposed to continuing down that path? So I'm curious if that was, if we might be going in that direction.
Yes. So the
Yes.
answer, so thematically, yes. So we're encouraging people to offer in trauma-informed services, and we've certainly done a number of efforts to reach out to providers to address that. There's certainly more to come. I think the challenge is that a lot of the children who are receiving the medications aren't necessarily in a very intensive level of care. So, you know, I think as an insurer and payer, we can certainly have an effect, but I think your all's role is also important, and the role of, you know, informing parents and guardians as well, because, you know, we hear about some people in treatment. We don't really have resources to evaluate every, you know, really intensively evaluate every child who's in treatment everywhere. But so we want to make sure that you all are informed as well, so that you have some sense of whether the treatment seems to make sense to you, and also that if it doesn't, or you're not sure, that you can raise your hand and say, can somebody help me evaluate this?
When you have a child who is in out-of-home placement, who is on multiple medications, and there is a possible concern about the amount and if they are still effective, do you have suggestions for the way to approach looking at that case to possibly make changes?
You really, I mean, what you're really asking is how can you make sure the child has a good evaluation and somebody's doing a good ongoing assessment of their care? So,
if
go ahead.
the child has been on that number of medications for a period of time, possibly making a change might disrupt or
Right.
have consequences, unintended consequences, but there's always the question of whether ultimately a change might be effective or have a better result, and
Right,
what's
for the
best way
child.
to approach that.
There's no simple answer, I think. I mean, you'd probably want to start, I think, with talking with the clinicians involved in caring for the child, but, you know, ultimately a lot of these, if you're thinking really critically and thoughtfully about it, a lot of times there's going to be children where the answer is not clear, despite all your good thinking. So I think really trying to pull together a team, you know, the team of people caring for the child, outline exactly what your concerns are, what you want to watch over time, so that everyone's on the same page in terms of a plan, is probably the best strategy. Sure.
Good morning. Is there any information that is available that might relate use of psychotropic medication to later use of illegal substances? You know, people's diagnoses follow them around. We have many children who, not for months, but for years, are prescribed medications to treat specific symptoms. And I'm just wondering, with discontinuance of that medication, if we see more individuals then turning to illegal substances.
I'm sorry, if the medication's continued or discontinued?
If it's discontinued.
Continued.
If there is an increased prevalence of use of illegal substances.
The only clear literature that I'm aware of is around treatment of attention deficit disorder. And there is some literature that indicates that if children are appropriate, that if that is their real diagnosis, then if they get adequate treatment, their rate of substance use is less than if they don't get treatment.
So can I surmise then that you're saying without adequate treatment, there could be an increased risk?
Yeah, that's certainly the implication of the work, that if children aren't treated, that there's a higher risk of substance use issues. And, you know, why, who knows, but, you know, it's probably at least partly related to the fact that part of the syndrome is that people tend to be impulsive and to do things without thinking very thoroughly about them.
My question is, what are your thoughts in regards to foster care youth being reevaluated for their diagnosis before they leave care?
Should the children be evaluated before they?
Reevaluated maybe every couple of years or before they leave care. What I have found is there's a significant amount of youth in foster care, as we know, who have been diagnosed with different diagnoses. We also know that they came into foster care based on grief, loss, trauma, and every individual reacts to these specific events in different ways. A lot of the ways that the youth are reacting may be age appropriate, but because of the circumstances that they're under, they may come across, as we know when we fill out the Connors reports and things of that nature,
Right.
that they have a specific diagnosis. So then they are placed on medications where, if they are misdiagnosed, that medication can kind of, fumble up their chemical imbalances. So again, my question is, what are your thoughts on reevaluating the youth who come into care and are diagnosed within maybe a couple of years, or just ensuring that they are reevaluated before they transition into adulthood? Because a lot of times they become dependent on that chemical, which I think is what the woman was trying to lead to, and then that's when it goes into other situations.
Well, certainly if the child's on a medication, they should be reevaluated periodically, regardless of, their living status. If the child's not on medication, I think it's, as you kind of alluded to, being placed in foster care itself is a trauma. So it's certainly appropriate for being taken out of your home is certainly a trauma. And so I think it's certainly appropriate for those children to be evaluated periodically. Whether it should be exactly at the moment they leave foster care, I don't know enough about the details of the system to comment on. But certainly the children have been through undoubtedly lots of trauma. They probably wouldn't have ended up in foster care. So it's certainly appropriate for them to be evaluated.
In your practice, have you found that there has been a significant amount of misdiagnosis based on the trauma and experiences that the youth have been going through, and it kind of makes it look as though they do have their diagnosis?
Our main concern has not primarily been with misdiagnosis, although that's not something we've looked at intensively, but more about whether or not the treatment that's recommended is appropriate based on the diagnosis or symptoms that the child has. So my time's up, but I'm happy to stay up here and talk longer, but I think you all are in time for lunch. So thank you very much for your attention.